All right, guys, let's get started. Remember, there are NCLEX style questions at the end of the hypertension PowerPoint that are due Wednesday. So there are NCLEX style questions, hypertension PowerPoint, which is already posted on Canvas, due Wednesday. We are in chapter 33 in your MedSurg text. This is just going to go over the pathophysiology of hypertension so we don't have to complete in class. Going over a few things, your blood pressure is the result of your sympathetic nervous system, your renal system, and to some extent the endocrine. We're mainly going to focus on the sympathetic nervous system and the renal system because this is typically where the meds that we're going to learn for this segment are useful or are effective. Looks like a complicated slide, but much of it should make sense. We've often talked about cardiac output. Well, blood pressure is actually the result of not just your cardiac output, but what we call systemic vascular resistance too, or SVR, which is what I will refer to. SVR, systemic vascular resistance. What is systemic vascular resistance? All right, well, when you think of the ventricles, they have a full load. They need to eject or get rid of this load. Then it is the pressure that the ventricle must use or come up with in order to get rid of that volume. And so on the left side of the heart, your left systemic vascular resistance, which is often referred to as afterload, that's the left ventricle's strength that it takes in order to overcome the pressure of the systemic circulation in order to get rid of its load. So it's kind of like a little Red Riding Hood. If it's just right, then the ventricle does not have to work too hard. It easily ejects its load or empties the left ventricle volume. If it is too high or too much, then the left ventricle, which yes, it is a muscle, has to overcome that high pressure, and that muscle has to work harder, and over time this can cause thickening of the left ventricle. If it's too low or too little, then the left ventricle will not eject all of its volume, and this can sometimes result in not emptying and result in possibly heart failure. So those are some analogies for what systemic vascular resistance is, and because we're talking about blood pressure, we're concerned with the left side, the systemic circulation, and this is called afterload. And so when you follow this down, what you guys are seeing here is there are a lot of different types of medications that we'll learn about for hypertension and how they actually work. And so for systemic vascular resistance, if it's too high, then we need to lower it. And so this is where we get into the vasodilators, okay? And the vasodilators, for instance, would be your nitrates. Okay, your vasodilators would be your nitrates, and we talk a little bit about them. But also vasodilators can be your ACE inhibitors, and you guys remember ACE inhibitors end with pril. Your calcium channel blockers, they also can cause vasodilation. And your angiotensin 2 receptor blockers, your ARBs. Your angio 2 receptor blockers, ARBs. Okay, we learn about some alpha blockers. So look, right here, dilators. These dilators can include alpha blockers, but they can also include beta blockers, which end in LOL. Then we get into the actual cardiac output. Cardiac output is made up of different different things are going on. Those include the heart rate and contractility. And drugs that affect the heart rate and contractility are your beta blockers and your calcium channel blockers and your centrally acting adrenergics. And so you can see that some drugs actually fit into more than one category. And then what drugs actually decrease circulating volume, helping with hypertension by not necessarily dilating, but by decreasing the amount of circulating volume. And you can see that's where we get again into the ACE inhibitors and your diuretics such as Lasix. So when we're learning the drugs for hypertension, you guys need to start to visualize this chart and ask yourself, where do these drugs that help hypertension, where exactly are they working? This is pretty self-explanatory, but we know that the renal system also obviously has a effect, right, on the blood pressure. And so what do we know? Let's say your person senses the fact that we have low circulating volume. The kidneys, the way they perceive that is, oh, low circulating volume. I need to help fix this so my blood pressure will go back up, right? And so what do we do? Or what does your body do? Your body increases the release of aldosterone. What does that do? Well, it's kind of what we call a round robin, as you can see down here. Then increased aldosterone causes the sodium to be more reabsorbed. Where sodium goes, there goes water. And so that combination leads to increased blood volume, and that combination leads to increased cardiac output. And so this is how the renal system is involved with hypertension. If we can block this particular cycle with medications, then we can help to lower the volume. And by lowering the volume, we lower the volume, we can lower the cardiac output, and that will too help to fix hypertension. So what you'll notice is often a patient who has resistant hypertension is they're on a combination of drugs that work in various ways in order to attack the hypertension by various routes. You guys check out the chart on page 712. You need to know this. It is essentially what is considered hypertension. So this got actually a little bit stricter a few years ago, and you can see that we can counsel someone and tell them that they have pre-hypertension, okay? Pre-hypertension if they have a systolic that's running 120 to 139, or a diastolic of 80 to 89. And that's considered pre-hypertension, right? So when is someone considered hypertensive? Well, it means that their systolic is greater than 140, or their diastolic is greater than 90. Now this is just not a one-time thing. If this person has no established history of hypertension, this has to be on 2 or more different visits. So if someone comes in, let's say I come into the doctor's office and my blood pressure is 145 over 92, then they're going to advise me to start to keep a log and to come back for a checkup to see where my blood pressure is. I come back in a month and it's still elevated, then I can be diagnosed with hypertension. Or if you have someone who comes in and they currently are utilizing hypertensive medications, then I can be diagnosed with having what is called essential hypertension, okay? We really, really need to catch people in the pre-hypertension stage and start to counsel them about lifestyle modifications, and we'll talk about these in class. In your book, we talk about primary versus secondary hypertension. Primary or essential is that the blood pressure is elevated and there's no identifiable cause. This obviously is the most typical or common type of hypertension. There are many risk factors, as you guys can read through, but most people have what we call primary hypertension. There are cases in which people have secondary hypertension. We can specifically say, okay, your hypertension is due to X, okay? And so this lists some of the different types of, or different causes of secondary hypertension. And so what do we need to do? We need to actually get after the causes, and if we can control the cause of the hypertension, then usually we can treat the primary disease and the hypertension will subside. I think most of you guys realize that hypertension is what we call the silent killer. Often there are no signs and symptoms at all. If someone does come in with signs and symptoms, a lot of times it can actually be due to the fact that they have another organ that's already being affected by their hypertension that's not being treated. Some people do come in, and when they come in, they actually have headaches, and that's one thing that's not listed on here. are headaches, and so sometimes headaches, especially in the morning, can be a sign of hypertension. Others would be they have fatigue, and the fatigue is actually significant enough that they have an activity intolerance. They're experiencing dizziness, possible chest pain, dyspnea, but headaches, that's key. But a lot of people, it's just sheer coincidence that they're diagnosed with their hypertension, possibly come up in for something unrelated, and they're diagnosed or start the process of being diagnosed with hypertension. So when we look at what's going to happen when someone has hypertension and it's not treated, then it damages other organs throughout your body. So it can and it will lead to coronary artery disease. It will and can lead to left ventricular hypertrophy. This is what I was talking about, guys, when you have that load, that volume that needs to be ejected from the left ventricle, and the systemic circulation or the systemic blood pressure is so high that causes the left ventricle to have to work too hard, and it develops a thickening. This thickening can then too lead to heart failure. And so when we talk about heart failure, the main reason someone has heart failure is coronary artery disease and hypertension. Hypertension leads to strokes. It can lead to retinopathy. And as we've already studied, it is one of the leading causes of renal failure. So this is the end of the pathophysiology. So make sure that you look at and complete the NCLEX style questions at the end of the PowerPoint for hypertension. Thank you.